Fibromyalgia is a fascinating topic. Let me just say right up front, there are no medications with an official indication for fibromyalgia. Now that doesn't mean that things don't work. It just means that companies have not yet gotten approval from the FDA. I will tell you though, there is a lot of interest among pharmaceutical companies to get that indication, and there are 3 or 4 medications that are right in the process of getting all the studies together. It takes a long time to get approval. Now, I've really been bantering around what's going to be the best approach, because there are all kinds of different ways to look at this disorder. And I was asked to give more of some of the science of it and some of the pharmacology possibilities. But then at the end, I want to also show you some things about a few non-pharmacological things that we've found some interesting data with recently. So let me just begin by saying that fibromyalgia is kind of a classical prototype of what we're calling central pain syndromes. And these are a very common group of syndromes. And what do I mean by that? Well, it's often involves central nervous system hypersensitization, that is over-responding to stimuli, and there's also, it's a form of what we call neuropathic pain. Now, you know, for years we used to divide pain more into acute pain versus chronic pain, because chronic pain is a very different entity than just prolonged acute pain. And people have tried to treat chronic pain as prolonged acute pain for years, but it doesn't work. Because it's a really different entity that involves this neuropathic part. It's even more useful to divide the pain this way into what's called nociceptive pain over on the left versus neuropathic pain over on the right. And the reasons are the mechanisms are different and the treatment is different. Now what we mean by neuropathic pain is caused by tissue damage. You know, you've got arthritis or trauma, or you've had surgery. So there's something out here in the tissue that's damaged. And that's the kind of pain that responds nicely to anti-inflammatory pills and opiates. Now on the other hand, classical neuropathic pain over here are things like the pain you see with diabetic neuropathy, or people who get shingles, and then after the infection's gone, the nervous system just takes off with post-herpetic neuralgia, where the pain is driven by damage to a neuron from the diabetes, or from the shingles, or from other kind of things. And then the neuron itself, that is, you know, you've got a pain generator out here. It sends a signal into the nervous system along a neuron. And the classical kind of neuropathic pain is there's no longer anything out in the tissue except the neuron itself becomes the pain generator because it's been damaged. But there's a second part to neuropathic pain, and that is when you have this damaged neuron, then the central nervous system starts upregulating and becoming hypersensitive to pain signals, where a little signal now becomes a big pain signal. Now, fibromyalgia is sort of here in the middle. I spend a lot of my time with this kind of mixed group, things like chronic low back pain or chronic neck pain or fibromyalgia, where you may have, say, a trigger point. Now, that's not the same as the tender point of fibromyalgia, but I'm talking about you get more little trigger points where you get muscle spasm. So that could be a nociceptive generator, but that's not the main issue. The main issue is the hypersensitivity that goes with it. That's the neuropathic component. And the reason for dividing them into those two kinds of pain is the treatment for neuropathic problems like fibromyalgia is very different than that for nociceptive pain. Opiates don't work very well. For example, anti-inflammatories don't work very well, as they do with nociceptive pain. But there's a whole host of other things that do work well. And that's what we're going to talk about. Let's talk just for a second about some of these very common central nervous system hypersensitivity problems. This whole group of things often overlaps with the fibromyalgia. And they're some of the most common medical things that we see. If you were to guess, of everyone going into a gastroenterologist with their belly pain or their bowel problems. What do you think the most common diagnosis is that comes out of a gastroenterology clinic? Okay, irritable bowel. We had Dr. Cole here not too long ago talking about irritable bowel. Half of everyone walking through the door to a gastroenterologist has irritable bowel. And there's another large group that has upper intestinal so-called functional problems like irritable bowel of the stomach or the esophagus. Now, if you do, so this is the majority of people going to a GI specialist. Now, if you biopsy the colon in irritable bowel or this non-ulcerative Pepsi kind of stuff, what do you see? Nothing. It's not a bowel disease. It's a very real, very common entity, but there are no tests for irritable bowel to prove it. Okay, now if you take the most, well, let me show you what irritable bowel is first before I go to the next step. This guy named Whitehead, I think I've shared this with a few of you. This guy named Whitehead did this sort of sadistic study where they take a catheter with a balloon on the end of it and they put it up in the colon of people with IBS, irritable bowel, that's the frowny face, and in normals. Okay, and they start blowing the balloon up and they ask them two things. How soon do you feel it and how much does it hurt? Now, the results were rather striking. In the normal folks, and I suspect some of these are med students trying to get a grade, you know, grin and bear this deal. Notice, as they blow that balloon up, they have to get up to fairly high volumes. They don't even feel it till you get up to about 100 cc's, and even above that, it really doesn't hurt. This is the pain over here in the volume of the balloon. So you've got to get up to pretty high volumes before it really is very uncomfortable in normals. But notice what happens with irritable bowel. A person feels it immediately at very low volumes, hurts way too much, and then you get an over-response of the nervous system, both the bowel nervous system and the central nervous system, over-responds to that gut stimulus with smooth muscle spasms. So now you get the diarrhea and the constipation, the bloating and things. Now my point is that this very common, very real entity, which half of people with fibromyalgia have, is not a problem of bowel disease out in the periphery. It's not nociceptive pain. It's a problem of a normal gut stimulus being responded to in a hypersensitive way, where the nervous system is over-responding to what should be a normal stimulus. Now, here's another illustration. Okay, fibromyalgia, you've all seen the diagram, those little tender spots, characterized by chronic, widespread pain, widespread above and below the diaphragm, both sides of the body. Chronic is more than 3 months, bothersome pain. Chronic widespread pain, all those little tender spots. Now, if you biopsy, let's say you take that little spot right there over the trapezius muscle, you know, that's usually quite sore. And you biopsy that, what do you suppose you see? Nothing. It's like biopsying the colon irritable bowel. It's not a muscle disease. But it's a problem of the central nervous system, just like IBS. It's like IBS of skeletal muscle. If you take those little spots, and anybody who does not have fibromyalgia out here, and we poke on ourselves on those spots, you'll find those spots are just a little more sensitive in everybody. Now, you know, the amount that a doc pushes is just enough to blanch the thumb. That's not hard. And normally, even though those spots are a little more sensitive, they don't really hurt particularly. But it's more sensitive than if you go somewhere else. Well, a little pain stimulus, central nervous system over-responds, just like the IBS, and a little pain stimulus becomes a big pain stimulus. It's a very real phenomenon. And we'll talk about why this happens. Well, here's a whole list of very common central hypersensitivity problems. They will look familiar because if you have fibromyalgia, you're very likely to have more of these other problems. The most common GI problem we talked about, over-responding to a person eats a bolus of food, and instead of a little stimulus that kind of creates contractions, it becomes a big stimulus. Okay, irritable bladder. Well, what's that? urinary frequency, it feels like a person has to go a lot. You check the urine, it's okay. You look in the bladder, it's okay. It's the same thing. It's like irritable bowel of the bladder. The bladder senses the urine too early, it's too uncomfortable, and smooth muscle spasm. The most common cause of chest pain is not heart chest pain, it's this so-called atypical or non-cardiac chest pain. Well, if we treat this with the same medicines I'm going to talk about for fibromyalgia, the atypical chest pain goes away in the majority of people. It's a problem of this central hypersensitivity. The most common pain problem out here in our clinics are headaches. Well, here's migraine. And incidentally, most headaches are a variant on migraine. Here's how you tell if you've got migraine. And about 60% of people with fibromyalgia will have headaches. Okay? If a person gets headaches bad enough to make them feel like they want to go to bed, sort of incapacitating headache, there are three things that they're a nice little tool, whether it's migraine or something else. If you get bad headaches, they're episodic. That's one. Two, if you get nauseated with them. And three, if light or sound bothers you a lot during the headache. Okay? If you've got two of those things, that's migraine. Okay? Even if it doesn't, you don't have all the other classical things that go with it. Well, what's migraine? Central hypersensitivity problem. Light hurts, sound hurts, stress, stuff that shouldn't hurt hurts. You see what's happening? The nervous system is over-responding to stimuli of all kinds. A person will have their migraine and their hair hurts. Just touch hurts. It shouldn't hurt, but it does because of this hypersensitivity problem. There are no tests for migraine. You can't get a blood test or a brain scan. There are no tests. It's a history, just like fibromyalgia is. There's a pattern of this hypersensitivity problem. Okay. Well, we talked about the fibromyalgia, and even this. Think about an anxiety disorder in combination with this hypersensitivity. Now, we're talking about disorders, not just, anxious because something bad happened, but I'm talking about where it's too much. A stress stimulus occurs, and the nervous system over-responds. A small stress stimulus becomes a bigger stress stimulus. You see, it's a twitchy nervous system. And if you have one of those things, you're very likely to have one or more of the others. Folks with fibromyalgia get more anxiety or depression kind of problems. Now, a third don't have those. It's not the same thing as just an emotional thing. It's just that the stress response is hyperregulated, just like the bowel or the pain response. And so they all overlap. And when you start treating the central causes of the hypersensitivity, all of those things diminish. So rather than just treating symptoms, we can use medications for each one of those to kind of put out the fire, but instead of treating the peripheral spasm or the migraine, and it's great to take a triptan for a migraine, you're just kind of putting out the fire. What you want to do is get rid of the underlying thing triggering the migraine and the pain. Okay, and that's what we're going to be talking about tonight. So how does this hypersensitization occur? Well, one little principle here, and whom is it more likely to occur? One of the pieces of that is there's a genetics to this. Okay, persisting acute pain in a person genetically prone. You have something traumatic happens. We've got nociceptive pain. If it goes on and on, inadequately treated, the nervous system starts upregulating if you're genetically predisposed. And then the nociceptor out here, that peripheral thing may be gone, but the nervous system's still overfiring to pain. Okay, and there's people particularly genetically prone. Here are a few things. I'm not going to talk about genetics tonight. I think Dr. Bateman did that somewhat in conjunction with chronic fatigue not too long ago. But here are some little enzymes and things that act on central nervous system. I think 5-HT is serotonin. There's a, down in a nerve synapse, because that's where a lot of the action is with this hypersensitivity. So you release serotonin, and then the serotonin is taken back up out of the synapse. Now, serotonin is released by this neuron, and it stimulates receptors over on the other side to send the signal on. Well, then the serotonin is taken back up into the neuron. The gene for the transporter that takes it back up, that's the little thing that gets rid of the serotonin. Abnormalities in that gene set you up to get more of this hypersensitivity. Genes for the 5-HT2 receptor. Now that's over on the other side. You have, serotonin 1, 2, 3, 4 types. Genes that sensitize that receptor make the person more prone to hypersensitize. And the COMT is a little enzyme that gets rid of some of these neurotransmitters. So if they're not working well genetically, the person's more prone. If they get some kind of pain generator, and it starts hypersensitizing, okay, even after the generator's gone. So here's a little diagram, and I shared this with a few of you, but it's helpful to kind of put this in perspective. So here's a little pain diagram. See, here's in the tissue some kind of trauma. Now that doesn't mean everybody with fibromyalgia had trauma, but this is just the diagram to explain things. Okay, so some kind of thing out here that generates a pain signal. That sends a signal in on this little sensory neuron into the spinal cord. Now, classical kind of neuropathic pain, like the shingles and the diabetic problem, that's where this neuron itself becomes hyperexcitable and becomes the pain generator rather than it out in the tissue. Well, fibromyalgia doesn't have this in the tissue nor a damaged neuron. But here's what happens. This signal then is sent up to the brain, and then the brain, and this is the point of this slide, the brain sends a signal back down to inhibit that pain neurotransmission. A lot of this hypersensitivity stuff is driven by problems with that inhibitory tract. It's not inhibiting things properly. That tract is driven by primarily 3 neurotransmitters: serotonin, norepinephrine, and dopamine. In fibromyalgia, all 3 of those have been shown to be hypofunctioning. They run low, so to speak, in terms of their function. And when that happens, the inhibitory tract doesn't work well. So now you have a pain signal coming in, just pushing on a sore spot, uninhibited, a little pain signal now becomes a big pain signal, because it's not being inhibited. So one of the key places we're going to be thinking about helping neuropathic or fibromyalgia kind of pain is how to improve that inhibitory tract. That is how to improve those neurotransmitters right there. Okay, I'll show you a little data on that. Now, for a minute, I'm going to get a little technical tonight, okay? And there's some reasons why I'm going to do that. I'm going to show you a fair amount of detail about this physiology because it helps be very creative how to treat these things, both medically and non-medically. Now, let's take a look at this synapse. So here's the incoming pain signal connecting with the second order neuron that's going to carry the signal to the brain. That's this synapse. Okay, in comes the pain signal. Now, just kind of follow along. This will sound a little technical, but you'll see it makes some sense here. When the pain signal comes in, the way it gets translated to the other side to go to the brain is these little things called calcium ion channels open. And as calcium flows into that neuron, it releases a pain neurotransmitter called glutamate. The glutamate is one of the most common excitable neurotransmitters. It's going to excite the other side to fire it off and send a pain signal up to the brain. Okay, now, on the other side, the glutamate opens some sodium channels and some calcium channels. And the more sodium and calcium that flows into this neuron, the more powerful the pain signal going to the brain. So, when people have neuropathic kind of problems, a hyperexcitable system, a little pain signal comes in and it ends up uninhibited with too much sodium and calcium flowing in on the other side, so you get too big of a pain signal. Now, this is where medications like anticonvulsants work. Let's talk about anticonvulsants for a minute. You know, fibromyalgia doesn't have anything to do with convulsions. But if you kind of think about this, people who have seizure disorder, convulsions, they've got a twitchy nervous system. You know, they're exposed to bright light, and everything goes bananas. You see what it is? It's a system that a little signal triggers too big of a response. Well, the way anticonvulsants work is to normalize the response to that stimulus, so the nervous system's not so twitchy anymore. And the way they work primarily is by blocking calcium ion channels or sodium ion channels. And different ones can work on either of those two things. Here's a little summary of that. Okay? Neural stabilizers, we call these medications. Some of them that block the sodium channel would be things like a drug called Lamictal, or another one called Topamax. You know, a lot of people use Topamax for their migraines, to prevent the migraines. Works nicely. Okay? Or calcium channel blockers. And now you've got things like pregabalin, that's Lyrica, or gabapentin, that's Neurontin. You may have heard those names. Okay, those are calcium channel blockers, and they work nicely for pain. The calcium channel ones seem to work a little better for pain than do the sodium channel ones. The sodium channel ones sometimes work a little better for some of the anxiety and depressive problems. And all of those, when you block those calcium ion channels and the sodium ion channels, they all reduce the release of the glutamate. Remember, that's that excitatory neurotransmitter that sends the pain signal. And interestingly enough, sometimes if we really get stuck, low doses of one that blocks this together with low doses of one that blocks that works better than just a big dose of one of those mechanisms. So, here's a little data. I suspect, this is the pregabalin, this is the Lyrica, this is off-label. I mentioned everything's off-label, okay, when we talk about fibromyalgia. But for example, here's a study using this anticonvulsant, this calcium channel modulating anticonvulsant. And what we're asking here is what percent of people get a 50% reduction in pain. So when we do studies on neuropathic pain, the FDA requires what they call a clinically meaningful response. And how they define that is this: a 50% reduction in pain. What that means is, many of you have probably seen that 10-point pain scale. You know, 1 to 10, how bad's your pain? Okay, and 10 is worse than labor, excruciating, you know, the worst imaginable pain. Okay, most people with fibromyalgia up around 7 or 8 on average. Okay? And that can often be disabling pain. So what they're asking on each of these medication studies is what percent of people get a 50% reduction. That's like going from 8 to 4 or less, which is not disabling pain. That's why it's clinically meaningful. Well, in this particular one, 30% of people get that 50% reduction with just that one medication, this calcium channel modulating anticonvulsant. They may well be going, but you know, they're doing more studies on this to see if they can go for an indication for that, just with the anticonvulsant. Also, better was sleep quality, fatigue, and their global impression. How well are you doing? Just kind of globally. Okay. Interestingly enough, it also helps the anxiety if that happens to be there. Now, let me just quickly summarize some of the neurotransmitter abnormalities that have been proven with fibromyalgia. Okay, low central serotonin and upregulated 5-HT2. That can lead to trouble getting deep sleep and getting more anxious when serotonin runs low. Incidentally, as I show you some of these symptoms, this will guide us, you see, which things we might choose, which one of these neurotransmitters to go after first, depending on which of the symptoms are predominant. Okay, low central norepinephrine. That can cause trouble with fatigue and more pain. Norepinephrine seems to be maybe even more important than serotonin for pain. low dopamine function. Remember, those are those three things involved with that inhibitory tract. Well, when dopamine runs low, people often have trouble thinking and trouble experiencing pleasure. Dopamine is the neurotransmitter of pleasure. Sexual response is a dopamine kind of thing. Ability to concentrate and focus. Medications that are used for kids with ADD are things that raise dopamine. High substance P. Well, what's that? We'll come back in a minute and I'm going to tell you what substance P is. It amplifies the pain. I'll show you how in just a second. And there's this abnormal nerve growth factor. Now this combination, the growth factor and the substance P, seem to work together to amplify or to quiet the pain. And they're both abnormal in fibromyalgia. Let me show you. Last year we had Dr. John Russell at our conference, at the Offer Conference. He's been a real pioneer with a lot of this neurochemistry in fibromyalgia. And he did one of the first studies right there showing that if you take cerebral spinal fluid out, that reflects the central nervous system, the substance P that magnifies pain is 4 times that of non-fibromyalgia people. And there have been 3 other studies that show exactly the same thing. Now, let's come back to that synapse, because this is where the plot thickens. Now, I told you we're going to get a little complex here, but I think you'll begin to see why is practical applications of this. Okay, here's that incoming pain signal, and here's the second order neuron over on this side that goes to the brain. When the pain keeps coming in, unrelenting, now something new happens. You start releasing substance P. The substance P comes over and turns on this thing called the NMDA receptor. And once it's turned on, it sort of indiscriminately starts opening sodium and calcium channels all over the place. So way too much sodium and calcium is flowing in. Now I told you if that happens, if you get too much, you get this big pain signal. And it happens not only at this level, but the next level up. The pain signal may be coming in from here, but when you've got substance P turning on the NMDA, it not only hurts here, it starts hurting up into the neck and the head and down into the shoulders, even though the generator may be right out here in this one place. The spreading pain signal. Okay, NMDA and this substance P is very much involved in this hypersensitivity, where a little signal now becomes a big signal. Here's just an interesting deal. If in this little diagram, this is it from both animal and human studies that shows this. See, here we are down here. The number you just measure the pain signal. You're going to stimulate this nerve, and you're going to measure the pain signal in the second order neuron. And notice they give one pain signal, then a second, then a third, then a fourth, then a fifth. And notice what happens. Here's the power of the pain signal. As this goes on unrelenting, you see what happens? It winds up. It becomes hypersensitive. And once hypersensitive in a genetically prone person, you can stop generating the pain signal and it just keeps signaling pain. Now, what's this orange and blue stuff? If you give an NMDA antagonist, okay, remember NMDA, this little receptor? So you block that thing before you start the pain signals. You don't get the wind-up. Here's the orange is on the NMDA antagonist, and that's without it. So NMDA antagonists are being looked at a lot, but what's coming out of that is it works great if you give it up front, but it doesn't work so well once NMDA is turned on. It's hard to turn it back off. There may be practical applications here. This is kind of future stuff, somewhat. But if a person who's prone to hypersensitize, someone with fibromyalgia, goes in to have surgery, see where you're going to start getting some pain signals like this, that may be the place where using an NMDA antagonist could be very useful. And often the anesthesiologist would give you something like ketamine, which blocks the NMDA. Okay. Now, this is the most complex, well, not quite. This is the second most complex slide. And I'm going to show you this because we're going to look at why don't opiates work very well for these neuropathic pain problems. Opiates are, of course, you know what opiates are: morphine, OxyContin, Duragesic, Lortab, you know the opiates, okay? Well, now here, this is that second order neuron. See, there's that NMDA we just talked about, and we've got substance P and glutamate coming down and stimulating that NMDA to turn it on. Well, here's a little opioid receptor. Now, I just mentioned this in passing. The more potassium you can get into that cell, the less likely it is to fire off. So if we can get potassium in there, it protects you from getting the sodium in to fire the neuron. Well, that's the way, in part, the way opiates work. The opiate stimulates this little calcium or potassium channel, and you get more potassium in it. It kind of hyperpolarizes the neuron, so it's harder to fire. But after the initial benefit that comes, see this thing down here called protein kinase C? This is a little enzyme. With a little time, the opiate starts stimulating that stuff. And that stuff starts blocking the effect of the opiate on the potassium receptor. And more importantly, probably, the opiate stimulates that protein kinase C to so-called translocate over to the membrane, where it turns on NMDA. The NMDA is blocked by magnesium. There's a little magnesium plug that won't let the calcium in. And that protein kinase C pulls the magnesium plug out, and the result is you get way too much calcium flowing in. Now, the plot thickens even more, because the more calcium that flows in, and remember, this is just a lot of pain signals can do this, turn on NMDA, and then you get too much calcium, or an opiate, too much calcium, and you start getting some breaks in the DNA, you know, the genetic of the cell, which through a couple more steps leads to damage to inhibitory neurons. You can see this actually in the spinal cord. If you're on opiates a long time, or if you just have lots of these pain signals coming in over and over again, you start literally seeing the inhibitory neurons start to shrink. Okay, now, this is what causes tolerance to opiates. What tolerance means is you stay on an opiate, it works great up front, but pretty soon it worsens the neuropathic process. And as that happens, you need more opiate and more opiate. Okay, and that tolerance is because it's worsening the neuropathic process. That's one of the reasons opiates don't work so well for neuropathic pain. They work great out in the peripheral tissue if it's out there. Now, well, this is a whole other story. There's some stuff called brain-derived neurotrophic factor that prevents this whole thing from happening. In depression or anxiety disorders, when the serotonin and the norepinephrine run low, BDNF falls off. And so when that inhibitory tract is not working well, you get more of this neuron damage. When you treat, in the absence of depression or anxiety, when you treat with antidepressants that improve the norepinephrine and the serotonin, BDNF goes up, and it protects you from this whole process. Okay, so there's some fascinating pieces here, whether or not the emotional part is there. You begin to see how we might be interested in antidepressants for these neuropathic pain problems. Here's just a bottom line study in neuropathic pain, 22 studies using opiates for neuropathic pain. Just give you the bottom line. This is visual analog reduction from placebo on a 100-point scale. Let's translate that to the 10-point scale. In all of these studies, the maximum or the average reduction was about 1 point, 1.4 points. That's not that 4 or 5 point that we're talking about with the other medications. It's about 1 point out of 10 is what you get with an opiate. It doesn't work very well. Neuropathic pain is kind of what I was saying. We talked about why that is. We have even had, this is curious, but people with neuropathic kind of things, this, and particularly fibromyalgia, who've been on opiates, and kind of takes the edge off, 1 point out of 10, okay? And you treat the other parts that we're going to be talking about, the neuropathic parts, and as we back off the opiate, in some patients, the pain actually gets better as you get off the opiate, which is an interesting phenomenon. Why? Because you're having less of that impact on the neuropathic process. Okay? Now, it's kind of complex, I understand, but you kind of get the point why your doctor with neuropathic pain might kind of discourage you about opiates, unless there's something else generating the pain to go with it. So, targets. Come back to our little diagram. I'm going to show you 4 targets that work for these hypersensitive neuropathic pain kind of things. One is the obvious, antidepressants, and I put there dual acting. Why? Because the more of those 3 things you improve, the better you do with the pain. So antidepressants that work on both serotonin and norepinephrine will do better than antidepressants that work only on serotonin. Some of the ones that work only on serotonin would be things like Prozac or Paxil, for example. Okay? And, well, I'm going to come back and show you what the dual-acting ones here are in just a second. So that's one target, is dual-acting antidepressants, whether or not depression is there. Dopamine agonists. Now, what are those? Some of you may know about restless legs. People with fibromyalgia get more restless legs. Okay, what is that? Well, this creepy, crawly feeling, it's too uncomfortable. Things that shouldn't hurt or bothersome. Okay, and when you move your leg around, you raise dopamine a little bit. And so there's tendency, going to sleep and this crawly, funny feeling. You move your legs around and it quiets down for a minute because you released a little dopamine. And the way you treat it? Dopamine agonists. We give drugs like Mirapex or Requip. Those are drugs that are usually used for Parkinson's disease. That's a different kind of dopamine problem, but they work great for restless legs or for grinding one's teeth. That's often a dopamine problem. Or for trouble thinking and concentrating. That can sometimes be a dopamine problem. Okay, and I'll show you the numbers on some of these different things in a minute. Here's another target. The anticonvulsants that we just talked about that work on that synapse, that blocking the calcium channels and sodium channels. And I mentioned other neural stabilizers. There are even some nutrients that act kind of like anticonvulsants to stabilize the nerve firing. We'll talk about those in a minute. And the 4th important target is treating the deep stage sleep, both pharmacologically if necessary and non-pharmacologically. And we'll come back and talk about the details of that in a minute. So there are the 4, those are the targets that treat neuropathic pain, and they work better than opiates or anti-inflammatories. Now, most people with fibromyalgia know one of those is a panacea. I mentioned that the pregabalin, the Lyrica, about 30% of people get a good response, but that means 70% are not. They might get a partial response. But see, here's what we can do now. These are all different mechanisms, and they're all abnormal. And so, you use one of the most obvious, and if that's not enough, you add in a second mechanism, and then another 30% gets a good response. Okay, and then if you need to, you add another mechanism. You treat them all. You have to treat the sleep in all of them. Okay? Because if you don't treat the sleep, it's really hard to get rid of the pain. If a person does not sleep well, all 3 of those neurotransmitters fall. This is really kind of fascinating. If you figure out how much sleep you need to feel good all day, that's how you tell if you're getting enough sleep. You feel alert, you don't need caffeine, you don't hit the wall in the afternoon, you don't get drowsy when you start reading a book or come to a lecture like this. I never get offended when people fall asleep in a lecture. It has now been proven that it's not boredom that does that. It's not getting enough sleep at night that does that. Okay? So it's either time in bed or quality of sleep. And people with fibromyalgia have poor quality sleep for a number of reasons. So you've got to treat that, or you have a hard time getting these neurotransmitters up. This is another thing I'm not going to talk about, but medications that block that serotonin 2 receptor will improve the deep sleep and help this neuropathic process. That's a little more complex thing. If a person has resistant anxiety and depression and resistant sleep problems, then medications that block that can often be very useful. But that's a little beyond our discussion tonight. So, what are these dual-acting, that is serotonin and norepinephrine kind of antidepressants? Well, the tricyclics, the older antidepressants, many of you have heard about using amitriptyline or nortriptyline. Nortriptyline seems to work every bit as well with fewer side effects than amitriptyline, but it's usually just low doses. We're not talking about antidepressant doses because there are too many side effects for most folks. I mean, they work great, except, you know, you get dry mouth and constipated and lightheaded and things. So most of the time we don't push those up to their full doses, but sometimes use a little dose just to help the deep sleep. Duloxetine, that's Involtin. There's actually data now. That's dual action, serotonin and norepinephrine at any dose that you give. And there's data, remember, 10-point scale, how many people get a 50% reduction? 30%. Okay, kind of like Lyrica, but it's a different mechanism. Okay, I'm rounding off the numbers a little bit. Then Lifaxine, that's Effexor. When you push the doses up to high doses, start bringing in the norepinephrine, the dual action. And one called Remeron, same thing, high doses, you start getting dual action. And Remeron helps the deep sleep. The others don't, except Tricyclics. Now, fibromyalgia often involves dysregulation. I wasn't going to talk about this, except last night some questions came up. How many tests should you run? And how should you address all of the abnormal tests? Because if you look hard enough, there'll be a lot of abnormal tests. And so this will be the most complex slide of all, but it's one of the more interesting ones in a way. Okay, involves many body systems. Most of these systems are involved with what's called homeostasis. That is, the communicative systems of the body are designed to keep things normal. Not too much, not too little. Everything balanced. Okay, that's homeostasis. Fibromyalgia is a problem with homeostasis. Should we be lumpers or splitters? Well, there's value to both. I'm going to show you the lumper perspective here for a minute. Here are the main communicative systems of the body. The nervous system, the hormone systems, and the immune system. They all have their communicative chemicals. The hormone system, you have hormones. Okay? And the nervous system, you have neurotransmitters and nerves going places to signal things. And the immune system, you have things called cytokines. When you're attacked by a germ, the immune cells release these cytokines that alert the nervous system and the hormones and create a reaction to deal well with this challenge, this stressor. Okay, now all those arrows show that there is a tight intercommunication between these. We tend to treat these as though they're separate. They are not separate. For example, now this is where, I'm just going to talk, you don't have to remember any of these details now, okay, on this. Just to get the general idea. In the brain, the same part of the brain that's involved with pain and emotion, the limbic system and the hypothalamus, the brain releases some of these neurochemicals that controls the hormone system, literally. If your thyroid hormone runs low, the brain picks that up and releases a thing called thyroid releasing hormone, okay? Okay? And it stimulates the pituitary gland to make the thyroid create more hormone. So the brain is feeding back to keep the hormone normal. Same thing is true with sex hormones, okay, or cortisol. You know, you get too much cortisol, goes to the brain releases a chemical that shuts it down, okay? You have to keep it in homeostasis, okay? It's a feedback system. On the other hand, the endocrine system, by releasing things like thyroid and the sex hormones and insulin, those hormones have a significant impact on the nervous system. For example, insulin, you think, you know, that's stuff that gets glucose into muscle cells to give you energy, and all kinds of cells to give you energy. Well, if insulin isn't working well, you have a hard time getting some of the nutrients into the brain to make serotonin. So if you have insulin resistance, serotonin is not made very well. And interestingly enough, if serotonin is not made very well, you get more insulin resistance. Your sugars go up. And you can see the pattern I'm talking about? Now, here's another one. Here are some of these cytokines we talked about. The immune system releases these chemicals that create inflammation. Well, the effect in the brain is, for all the world, like creating depression. I mean, think about this. When you get the flu, you know, you're tired, you're achy, things aren't fun. You know, sleep is it's like having depression, okay? Because those immune transmitters affect all of the neurochemicals in the brain that are related to pain and depression. You get more achy all over the place, okay? On the other hand, here's another one, histamine. You know, the immune system, one of the reasons you might get a rash or hay fever, you know, you got histamine being released. Well, in the brain, histamine wakes you up. Histamine is part of the wake-up system. If you take Benadryl, an antihistamine, it puts you to sleep because you're shutting off the neurochemical histamine that wakes you up. You can see what I'm saying? Is the point of all this is these things are totally integrated. Okay, even down here, in the nervous system, those monoamines, that's things like serotonin, norepinephrine, if they don't work well, your immunity does not work well. You can upregulate it or you can downregulate it, depending on where the problems in the brain are. And there's even more to it than that. The hormones down here, cortisol will shut off the immune system, and the cytokines can change the hormone. Now the point I'm making with all this complex stuff is this is a whole integrated system. When you dysregulate any one piece of that, for example, growth hormone. Okay? We'll talk about growth hormone here in just a second. Growth hormone is abnormal in fibromyalgia. But now notice this. See, we can dysregulate any one of these parts, the stress system. So you distress it where the nervous system feels like things are out of control. Well, it's not just the nervous system that dysregulates. You dysregulate immunity and you dysregulate hormones. When things are distressful, when the thinking feels like things are out of control, the immune system is out of control, either too much or too little. On the other hand, you get an infection and you dysregulate immunity, which we talked about a minute ago. You know, the nervous system, things don't quite work right, and hormones get fouled up. Or you get hormone changes. You know, a person genetically prone to this and suddenly has a hysterectomy and boom, down goes the estrogen, dysregulates hormones, and boom, you get headaches and pain and trouble sleeping and behavioral change. You see what I'm saying? This whole thing is all integrated. Now, some people would like to test all of those things, and that can cost thousands of dollars, and you're going to find abnormalities. But it doesn't mean that it's the insulin that's the problem necessarily, or even that it's the growth hormone that's the problem. I'll show you why growth hormone is low here in a minute. Mind you, giving something to treat that may help symptoms a bit. But my point is, what we need to do is re-regulate this whole system, and then all of those little pieces start falling together without lots and lots of tests and lots of supplements and medicines for every one of those little pieces. That's the point of this long discussion. Okay. Now, some nutritional considerations, because sometimes nutrients are used for a lot of those pieces. There are some nutritional things that can help. For neuropathic pain, here's some data. High doses of B1, B6, B12, and folic acid have been shown in people, in both people and in animals who have neuropathic pain and they're put on Neurontin. When you give high doses of those B vitamins, you don't need as much Neurontin, and it augments the effect of the Neurontin. The B vitamins have some nerve stabilizing effect. One other valuable one, omega-3 fatty acids. You've heard a lot about those for preventing heart attacks and strokes. Well, here are a number of studies. I won't go through the details, but this is high doses of things like fish oil and flaxseed oil and those little membranes. Remember, down in the cells where all that neurotransmitter action is in the membranes, those membranes involve omega-3 fatty acids. And when you use high doses, you stabilize the membranes, make the receptors and things work better. So we quite often will use 4 to 6 grams a day of omega-3 fatty acids and some of the high doses of those B vitamins. You can even get them in combinations now that are to treat homocysteine, to prevent heart attacks. Well, the little combination is high doses of those 3 things in one pill. And now I hesitated whether to put this in. There's not a lot of studies on this, and this is pure anecdote, okay? There are a few little suggestive studies, not well-controlled studies. But this thing called L-arginine in that dose at bedtime, in some people, not everyone, but in some people, seems to help the fibrofog quite a bit. Okay, and you see that also in things like narcolepsy, where they have fog. But that's pure anecdote, just for what it's worth. It's over the counter. Okay, now, what about the sleep abnormality? We'll kind of walk through this kind of quickly and then see if we can summarize things a little bit. What do we mean by deep sleep? Here are little bars that indicate the depth of sleep. You've got stage 1 and 2 sleep, it's light sleep, and on an electroencephalogram, the neurons are firing all over the place. It's because they're sort of all doing their own thing. But when you get into deep sleep, this delta, what you see is the neurons start firing together, and you get these big, deep waves that go like this. Now, in fibromyalgia, not only do you, and it's during deep sleep, I should mention this, that you get a lot of body repair and the secretion of growth hormone. It's primarily during deep sleep that you get growth hormone secreted. If you don't get deep sleep, things don't repair as well, and growth hormone falls, and you feel bad when growth hormone falls. Now, you can take shots of growth hormone, and it costs a lot of money, and you feel better. But my point is, the reason the growth hormone is low, it's not a primary problem in the pituitary gland secreting growth hormone, it's that you're not getting deep sleep. What you want to do is restore deep sleep, and then the growth hormone comes back. I'm going to show you a drug just in a moment that restores deep sleep, and up goes growth hormone back to normal. Okay, you got to treat the deep sleep anyway. So you get my point about not necessarily treating all the pieces. Many folks with fibromyalgia, about a fifth in our experience, have a thing called sleep apnea. And it's not necessarily the classical picture of the person you suspect. We often see this in, often you kind of think of overweight men with a big bull neck, where they obstruct their airways. But this is in skinny women with fibromyalgia. About a fifth will have sleep apnea. What is it? Well, as you get deeply relaxed in deep sleep, the airway relaxes. And as you get really relaxed, it may just close off. And as the airway closes off, that's the apnea, stop breathing, then the oxygen level goes down, and that signals the brain, hey, suffocating down here, get that airway open. And all night long, the nervous system is firing off. Now, you don't wake up, you just go into light sleep. So all night long, the nervous system's firing. You get stress hormones going up. That can cause more weight gain and all the things with stress hormones. And it carries over into the daytime. You get high blood pressure from this. Often one of the tip-offs is snoring, because as the airway starts relaxing and the air bubbles through, and you get a little snoring. And so if you're wondering about it, have partner watch and see if, snore along and kind of peters out, and then there's this sort of pause, 10, 12, 20 seconds, and you start breathing again, okay? That's a real tip-off, because if you don't treat the sleep apnea, you never get into deep sleep. And you can't get rid of the pain unless you treat the sleep apnea if it's there. So excess day sleepiness together with snoring, maybe hypertension. I'm going to do a test for sleep apnea. Okay, it's kind of important to treat it. People feel a whole lot better if they have sleep apnea when you treat it. Antidepressants inhibit deep sleep. And some of the old sleeping pills, like Halcyon or Restoril, can inhibit deep sleep. They put you in light sleep and keep you there. Here's a list of medications that improve deep sleep. Tricyclics, Flexeril, Trazodone, things that block that serotonin 2 receptor. The one that does it the best is this natural neurotransmitter called Gammahydroxybutyrate. And it's kind of unique. Let me describe something that you see quite consistently in fibromyalgia. Remember I mentioned these big deep delta waves? Well, it's not just that you lack the deep sleep. There's a thing called alpha intrusion. Now, what does that mean? Alpha is like awake EEG, and the delta is like a deep sleep EEG. And what you see is part of the brain is awake and part of it's asleep. And so you get alpha intrusion on delta waves. Okay? And the only thing that gets rid of that is this natural neurotransmitter, Gammahydroxybutyrate. You make it normally. And it's on the market. It's used for narcolepsy. Let me show you this. Last year we also had Marty Sharp, who did some of this research with this. This is the date rape drug, incidentally, folks. It works well for date rape, and you get this pleasurable deep sleep. Okay? The drug itself has now been changed, so you can't put it in people's drinks. It's too salty. The original thing you buy on the street is not salty, but you don't know what the quality is. And here's a percent improvement the next day after just treating this deep sleep with this neurotransmitter. The overall pain, see, this is the improvement, the overall fatigue improvement, and the deep sleep improvement. It's about 30% of people who get a 50% reduction. So here's just a little summary of these targets we talked about from a medication standpoint, where we've got some data. And I've rounded these off just to make it easy to remember. The Lyrica, about 30% of people get a 50% reduction. Cymbalta, about 30%. GHB, about 30%. Okay, and the Mirapex, that dopamine agonist, like used for Restoril, about 40%. But remember, those are all different mechanisms, and you can start adding those pieces together as you need to. So if a person, which one would we choose first? Well, you've got to treat the sleep, for sure. And I might just add, there are a host of important non-pharmacological ways to improve the deep sleep. some deep relaxation techniques and meditative techniques and imagery and progressive muscle relaxation. If a person is having trouble sleeping, it's very worthwhile to learn that stuff. In the long run, works better than medications do. Okay, question is, what about exercise and sleep? It depends on the timing of the exercise. It doesn't even have to be a lot of strenuous exercise. Exercise clearly improves deep sleep. But it depends on when you do it. When you do exercise, it raises your core body temperature. And that revs things up. So if you try exercise before you go to bed, you'll be kind of revved up. It's hard to sleep. But if you, 4 to 5 hours after you exercise, the body temperature falls. And when it falls, you get sleepy. And you improve deep sleep. So if you're going to exercise for sleep, late afternoon, early evening, 4 or 5 hours before you want to go to bed. If you exercise in the morning, you may find you're getting drowsy after lunch. This core body temperature falls. Okay? But clearly, exercise will help deep sleep. And the exercise also raises those neurotransmitters. Up goes the dopamine. Up goes this norepinephrine. You know, the things we're trying to treat with the medications, exercise raises those things up. Now, however, with fibromyalgia, remember, a little bit of pain becomes a lot of pain. Okay, so, and a lot of folks are out of shape. You know, it hurts and, you know, and tired. And the muscles get deconditioned. And so if you're going to do exercise with fibromyalgia, you start low and slow. Because all of us, I mean, you think about this, exercise helps the pain, but not initially. Okay. All of us have probably experienced this. You've been out of shape, and you decide, I'm going to go get in shape. And you whale into a big exercise program. And you remember how you felt the next day? I'm talking about normal people. Okay, you know, the next day, achy and stiff. But as you keep exercising, what happens to the pain? Goes away, doesn't it? As the muscles get reconditioned, they hurt a lot less. But with fibromyalgia, if you over-exercise and you get a little bit of pain, it's going to be a lot of pain. Okay, so the point that I'm making is you start low and slow. You know, go walking for 10 minutes. Or 5, if 10 minutes is too much. And then every few days, increase it by 5. And then pretty soon you can add a little upper body strengthening as you walk. You just do some simple little isometric things, or maybe get some very light weights. But just very slowly, you get those muscles strengthened. And as you do that, they hurt less over time. They hurt less, and these neurotransmitters go up. Okay, so exercise is very useful. It's good proof of that, but you can't do it too fast. Okay, if one night you choose one thing over another, well, here's just an illustration when we might choose a dopamine agonist way up front. You know, if there's not a lot of the anxiety going on or tingling, which you'd use an anticonvulsant for, if a person has things like associated restless legs or the teeth grinding or trouble thinking, maybe we would want to consider using one of the dopamine agents, because remember, those are the symptoms of the low dopamine function. So you begin to see how you start making sense out of what seems like a very complex problem, and is, but when you start seeing how it fits together, you can make some sense how to use different medications. Now, I'm going to shift gears for the last little bit, and I think last year we spent a whole session just on this part, which is fascinating to me and very useful for anyone with this stuff. I've mentioned that interventions improving chronic pain require improving these different neurotransmitters in deep sleep. Well, here are some non-pharmacological things that affect those neurotransmitters. The effect of so-called cognitive behavioral things. How do you think? Attitudes. How do they affect those neurotransmitters? Well, if you have an increased sense of control, up goes serotonin. There's fascinating studies with this. Don't have time to walk through them, but now there's a paradox about control. The more you try to control the world out there, the more out of control it feels. But But the more you respond to it, the way you would love to be able to respond to it, the way you would admire in someone of great wisdom or goodness or strength from your value perspective. You clearly identify that, and you are that. You feel personal control no matter what's going on out there. Up goes serotonin. It's like taking an SSRI, an antidepressant. Here's another one. Loving cooperation. We call it connectedness in the literature sometimes. Raises dopamine. Dopamine is the neurotransmitter of love. Okay, and you feel loving relationships, up goes dopamine, with all the things that those dopamine agonists do. Okay, so a sense of control and some connectedness, feeling one with. And it doesn't always matter a lot what's one with. It can be a loving relationship, it can be a dog. Okay, it can be sources of spiritual strength, oneness. Okay, up goes dopamine. You feel good. Exercise, excitement, getting turned on, finding meaning in what you do. My work has meaning, this encounter has meaning, I'm making a difference in life, getting excited about something, up goes norepinephrine. So, control, connectedness, meaning, and there are a number of techniques such as meditation. Up goes serotonin, up goes the GABA. When you raise GABA, now you're going to get GHB. Okay? Up goes to sleep. So now you begin to see some interesting pieces to this. Now, let me show you just a little science to this. There's lots of data that shows not only this, but the effects of those three things, and the fourth one is hope. Let me show you what that does neurochemically. But those four things have a powerful impact on stress resilience, where you can deal with whatever comes up. Let me show you the study we just did. This is kind of fascinating to me. Determinants of illness. There's an older test that's been well validated called the CIPI, the Chronic Illness Problem Inventory. And the score that one gets on this CIPI has been shown to significantly impact the outcomes on pain. There are three components that have a powerful effect. The most powerful of the three components on this is called the psychosocial factors. The psychosocial factors largely determine, now this is very careful analysis, this is sort of error-free analysis, how this factor impacts on this, okay? This is good science. The psychosocial factors largely determine how well a person functions, ADLs means activities of daily living, and the pain, and their focus. So psychosocial factors determine the total CIPI, which affects the pain. Now, we correlated this well-validated test against a new one called self-efficacy scale that we've created. And we looked at those four factors that we have seen in the past have significant health outcomes. Hope, control, meaning, and connectedness. Now notice here, hope, these correlations, these little numbers here, they don't mean much to you. Anything above 0.3 is a good correlation. Look at that, that's 0.95. It doesn't get much better than that. 1 would be absolute correlation. Okay? Hope significantly impacted the psychosocial function. The hope and the connectedness powerfully impacted the sense of control. So these four things, the self-efficacy, largely determine the psychosocial factors, which strongly impacted the pain and the ability to function. Well, now that raises some fascinating questions. How do we improve those four factors non-pharmacologically that then impacts all the rest of the story about function and pain? I'm going to show you just one little technique. There are a lot of ways to approach this, but here's something we've been doing in a thing called the stress medicine program. The first thing is it has to be experiential, not just talking about hope and control or how I would rather respond. You have to practice doing it. Literally, experience it, okay? And then things change rather quickly. Here's just a little, last thing I'll show you here, a little schema that really tends to work for all 4 of those factors. First is just the awareness. I can respond any way I want. This is half the battle. You know, what's going on out there, or the pain is here, and if the feeling is, it's got me, I have to be miserable when it happens, or when my kids are acting up, or you know, whatever it is that's getting to me. If it's controlling me, the stuff all goes to pot. On the other hand, half of the awareness is, it happens, the pain is here, but I can be in charge of me. Okay? This is a very important awareness. I can choose to respond to this miserably or creatively, kindly, angrily. I'm in charge of that. That's half the battle. So then the next question is, some deep relaxation skills to let go of the old thinking. Well, you gotta hate this when this goes on. Okay, well, maybe you don't have to, okay? You just let go of that thinking. Get deeply relaxed, which quiets the nervous system. So that's things like relaxation skills, but also meditation and a number of very valuable things. And the nervous system just quiets down. Remember, we talked about that happening? You get centered and focused. Don't know the solution yet, but you're just in a centered place where new possibilities can occur. And then you clarify your own deep wisdom. How do I want to be? Given that what's here is here, how would I love to be able to respond? How would I admire in a person of great wisdom and character doing this? And you get it very explicit, very carefully. They're your own counseling. And then, to wrap it up, you do some simple things like visualizing being that way. You practice, there you are in the middle of this confrontation, and it's like you create a movie, and you watch yourself doing it the way you've just designed, and then when you feel good about that, you put yourself in the movie, and there you are, in your mind's eye, doing it. You practice that 4, 5, 6 times for that particular situation, then you do it for another one, and you do it for another one, and pretty soon this wisdom starts to generalize. I know how to do this now. I can handle this well. Hope. I can handle this well. Something good can come out of anything that I'm confronted with. That's hope. Control. I'm in control of me. I can be the way I want no matter what's going on out there. If it's a relationship problem that's causing the stress, deeper connectedness. A conflict can draw you closer together or tear you apart. So you just ask, is the way I'm handling this connecting us or disconnecting us? Okay? You can even start finding meaning in every little thing that comes up to teach me something important about life. People who see it that way are more resilient. Simple little process, but it needs to be an active process, not just kind of talking about it. Okay? So, a little summary. Some ways to treat these chronic over-responsive pain disorders like fibromyalgia, headaches, irritable bowel, and so on. 5 important parts. Number 1, we didn't spend much time with this, but the earlier the better. Don't let that nervous system wind up and become hardwired from neuron damage to over-respond. Early is the name of the game if you can get it. Treat those neurochemical problems. We talked about antidepressants and anticonvulsants, the dopamine agonists, some nutrients even that can play a role in stabilizing neurons and helping them to fire appropriately to stimuli. Treat the sleep well, particularly the deep stages. Graded exercise, slow and easy, okay? And these experiential stress resilience things that raise those four neurotransmitters. Hope, internal locus of control, connectedness, and finding meaning. Hey, now let's entertain thoughts or questions about all of this stuff. I hope you can see why a disorder like fibromyalgia becomes very interesting and meaningful to treat, because it's not just treating pain, it's treating this whole experience of life. Yes?
For me, several years ago, trying the various antidepressants became an odyssey. And I found that some did nothing, and some actually made my sleep pattern much worse. There are some pharmaceutical companies that will make exceptions from their formulary if you have good reason. So I would encourage people to keep a list of what they have tried and the reasons why they didn't work, so that as time goes on, you can present your insurance plan with that list, or your doctor can, and request that exception.
Okay,
very often that will work.
This is very good counsel. Keep track of what each thing does, because sometimes there are resistances in this whole thing if you're not treating the other pieces. Don't get me on formulary. Formularies are very narrow. You know, it's only compared for one little piece of this thing, and it doesn't work. But if you really have trouble with almost all of the antidepressants, that's where some of these so-called neuroleptics that treat the serotonin 2 receptor come in. Okay? So it's just something we didn't have time to talk about.
When you talk about the nervous system and the immune system, and you talked about the inflammatory, when infection affects the hormones, does this affect sleep and deep sleep?
Yeah. Anytime you get the inflammatory system keyed up, then sleep often is significantly impacted. And vice versa. If you don't sleep well, your immune system doesn't work well.
So then what about using, like, prednisone as an anti-inflammatory to quiet the nervous system? Is that
sometimes
impact?
Yes, sometimes prednisone will give you some short benefit. It depends a lot on the rest of the neurochemistry. Prednisone in some people will quiet things down very nicely short term. But remember, prednisone has a whole bag of other problems if you keep taking it. In some people, prednisone will activate things. It really depends on some of the other characteristics. If a person has a little tendency towards a bipolar disorder, you get paradoxical responses to all these medicines. And that's where that 5-HT2 blockade can come in. So in some people, and I don't want to go into the details of it, it's not just the inflammation. The prednisone also suppresses a neurochemical called CRH that causes a lot of anxiety and activation of the nervous system. It's a hormone. It's not just acting on the immune system, it's acting on the central nervous system. Prednisone is a problem long term. You know, sometimes it's helpful short term. If we have a person that has an intractable migraine, and you really can't block it, a few days of prednisone can often just get rid of it. But you don't want to keep giving the prednisone.
Heard of a new sleep medication called Roserum. Is that good for this?
Okay, Roserum is a melatonin agonist. Roserum is unique. What I mean by melatonin agonist, it's not a sleeping pill in the sense of putting you to sleep. What it and melatonin do, and Roserum is better than melatonin, but what they do is they shut off the waking system that's caused by light. You know, when it's light in the morning, it wakes you up. Well, that shuts off that system. So it's more subtle. It's kind of like a lullaby instead of a hammer for sleep. Yeah, you might take the Roserum, or that's a whole other story. Yeah, you know, the sleep phases and so on. Roserum is very good for treating if your sleep phase is shifted. You know, you want to go to bed too early, wake up too early, or in kids, you want to go to bed 2 o'clock and get up at 11. You can shift the sleep phase nicely with Roserum, but it's not going to knock you out to sleep. It's a very useful medication in the right setting, but it's subtle more than...
When I had insurance, Ambien really helped my sleep. I think it's expensive, so when I lost my insurance, I started taking melatonin, and that helped a lot.
Melatonin is like what we just talked about. It works more on the... melatonin data for insomnia is not very good, but if you have the sleep phase problem causing what seems like insomnia, then it can be useful. Ambien does not suppress deep sleep the way some of the old sleeping pills do, nor does Lunesta.
I saw an infomercial that said sublingual vitamin B12 was much better than other ways you can take it.
Well, as I mentioned up here, high doses of B12, and sublingual just means it gets in more quickly. It acts like a neural stabilizer, and sometimes it can be helpful. I don't have studies on B12 and insomnia. I don't know.
When you were talking about the too much calcium and sodium ions, is that something that you can actually reduce in your diet? Would you recommend reducing the calcium and sodium?
The dietary things probably don't have major impact. Now, you want to get adequate calcium, but it's not like if you take calcium supplement, you're going to get more pain necessarily. There's more to it than just how much calcium you eat. It depends on where it is. In the brain, calcium is kind of quiet and interesting.
Would you please comment on Tylenol, PM Tylenol, Celebrex, Vioxx?
Yes, Celebrex and Vioxx are anti-inflammatories. So they work nicely for the nociceptive pain, like the arthritis or surgical pain. I mean, they're great. One of the things that's nice about Celebrex and Vioxx is they don't affect the platelets that cause bleeding. So you couldn't used to use NSAIDs very well because you get too much bleeding, but you can use Celebrex and Vioxx before surgery and end up with a lot less need for pain medicine. But that's a nociceptive pain. It doesn't work very well for neuropathic pain. And the other one was Tylenol PM. Tylenol PM is primarily Benadryl. It's an antihistamine to put you to sleep. Most sleep docs do not recommend antihistamines to put you to sleep. There's some other effects of antihistamines that aren't so good, and one of them is weight gain if you take it regularly.
I had a question about the vitamin B. How high a dose should that be?
Okay.
Talk about a high dose.
Yeah, B12 is going to be like 500 milligrams twice a day. B6, 25 milligrams twice a day. You don't want to go over 100 milligrams of B6. That can be neurotoxic. Folic acid would be something like 1 to 2 milligrams twice a day. The B1, B2 would be up in the range of a couple hundred milligrams. So we're talking big doses. This is not once a day vitamin doses. And this is a pharmacological effect different than just the usual what you eat in your diet effect.
What would you recommend in your daily diet?
Well, it depends on the rest of the story. If you want to get serotonin up, you need foods that have tryptophan in them. Okay, you need the building blocks for any of these medicines to work. Foods high in tryptophan would be things like turkey or dairy products or nuts. Okay, I mean, if there's any questions, sometimes you can even take supplements of the little amino acids. Amino acids are things you eat that are turned into these neurotransmitters. Okay, so it kind of depends on which one you're after. For the dopamine norepinephrine, there's a supplement called D-L-phenylalanine, which is an amino acid, and that can be helpful for those. I think we have time for one more question.
I've had the test for sleep apnea, and I'm on the CPAP machine.
And you like it? No,
I wish I did.
don't discourage these people.
Why doesn't it sometimes help you as much as it should?
Well, two things. You have to be sure you've got the right pressures and things. A surprising number of people take it off about half the time in the middle of the night. Okay. But even with the best treatment, the right pressures and using it all night, sometimes there's still some tiredness, and then there's ways to deal with that. to help with the tiredness medically. That's where things like Provigil come in. It actually has an indication for persisting tiredness and treated sleep apnea. I mean, there are ways to deal with that, but most of the time it helps a lot. Okay, I think we better call it good. Thank you for all your attention, sticking around so long. I hope it was useful.